And it's been shown time and time again, the anatomy is visualized better. There are less esophageal innovations, which we know esophageal innovation is a huge cause of morbidity and mortality.
Michael. So I'll jump in the fire since you didn't ask me. Yeah, I would still, even though I trained with DL, if I had to do an airway right now on any of you, I would grab the video. I think the one exception to that for me, at least in my practice, and I think it's because I've only ever worked with GlideScope, and I try not to use brand names, but again, as you said, it's a hyperangulated blade, and almost every bad PEET intubation that I've had in the last 10 years that we couldn't get with the GlideScope, we get the actual Miller out, the real Miller, and we're in 4 seconds. So I'm not saying I'm looking forward to my next pediatric intubation now that we have the CMAC with the Miller, but I think that's going to go better. I too have worked in community hospitals where we have video in the ED, and then you go upstairs and you're like, wait, oh, that's all we got. That's okay. As far as for the residents, I think you're going to use video wherever you go in your training, both in the ED and anesthesia and the ICU. But you need to know both, because technology breaks, stuff happens, you got to know both. And there's been times where I couldn't get it with the DL, and I get the video out and I look, and vice versa. And I think that's part of, as Salim said, the ABC. You can use both, that's okay. It's not like if you use one, you've got to go to surgical or do something else. Try the other one, it's a different technique, right? If you do the same thing the next time, without changing something, nothing's going to change. With a different piece of equipment in your hand, it's a new attempt. You can do something different, there are subtleties between them, and it gives you a better chance.
I just have one other comment. So there have been a couple of studies done by the same author, Driver, Ryan Driver, I think is his name, looking at bougie first innovation. And those were both single center studies, and I think it's still yet to be externally validated, but I think many of us are starting to sway to this bougie first innovation. The problem, if you look at those studies, is that the bougie is, if you know what I'm talking about, is not a malleable bougie. There are malleable bougies out there, but most of us have that cheap blue plastic one that you can't kind of bend into a certain shape. And it's ideal for a standard geometry blade and not a hyperangulated blade. It's actually a lot harder to get it in with hyperangulated. All the studies, they were all CMAC studies. So I think that also knowing how to do DL, if bougie first becomes our go-to and we see the high first pass success rate, that yeah, CMAC I think is going to be, again, I get no money from any of these companies, but I think CMAC is like the best of all worlds. You get a standard geometry blade that's DL and VL, and so you could do bougie first, you could turn on the camera and take a look and see what your residents see. So
we're going to probably go to every other day, so evens, we'll do odds and evens. That on evens, the resident gets to see the screen, on odds they don't, but as attendings, of course, we get to see it every day.
So just the take-home points that I would have from this are, first of all, I feel that like the VL, to me, feels more comfortable and is my go-to. However, it is a little bit more difficult to get to the point where you can use that well with some of those strange situations such as secretions or emesis or blood. And there's a way you can do it without a doubt, but you just need to make sure that you do the approaching, do the airway first, all that sort of thing. Rich Levitan has an airway course, and they have this model where it actually has like this green emesis that comes up while you're trying to like this double suction sort of thing, but using the VL with that. Anyways, just make sure that you don't go too far on the DL side and don't know how to use the VL, because to me, it seems like VL is the harder one to learn how to use, but once you've learned how to use it, it has a better, at least a decrease, what the studies show, chance of having esophageal intubation. And then most importantly, really, whatever you're most comfortable with. And that's going to be the difference, because in this room, one technique will be better than the other for a lot of us because we've done it more frequently, we're more comfortable with it. So let's move on to our second half of this discussion, which will be the trach patient. So this isn't as much of a controversy one way or the other, but we're going to talk just about some different tips and tricks, use the experience in this room to think about some of those pretty difficult and sometimes anxiety-provoking situations. So Rachel, why don't we start with you? You were going to sort of summarize for us the 3 main trach emergencies.
So when thinking about tracheostomy emergencies, there are 3 big ones, like Dr. Weinstock said, and I think about them in my head in terms of the ODB. So obstruction, displacement, or bleeding. And when you're assessing these patients, there are four main things that I would look for first. One, is this a patient who is in extremis and needs immediate intervention? Two, you need to know, or it would be helpful to know when this tracheostomy was placed, if it's within the past week or if they've had it for 10 years. And thirdly, do they have just a tracheostomy, or is this a patient who's had a laryngectomy? Because that means obviously you have no communication between upper and lower airways, and it is a different set of interventions. And then bleeding, are they still bleeding? When was the trach placed? Goes back to that one. And is this something that you need to do hemostatic control right away? So those three major things, and then that is kind of my initial assessment of the patient. And one of the first actions would be mobilizing your resources. So who did this? Was it your ENT? Who manages these things at your facility? And if you don't have someone at your facility that manages these, and this is a critical patient, mobilizing your resources for getting them to the place that they need to be.
Yeah, if you're deciding you're calling an ENT for a trach emergency, certainly on the road sooner rather than later. Obviously, it might even be 20 minutes before I call you back, right? As we sort of saw with some of the difficulties with that mock trial at Ohio State just in the spring last year. So, Mike, why don't you just start on the end here? Let's first talk about the obstructed trach. I mean, obviously, we're going to suction that patient, but what other tips and tricks beyond that initial approach do you have that you teach with the residents?
So I'll admit, I try to avoid trachs all the time. One of the things that freaks me out is tubes sticking out of people that aren't supposed to be there. Like, my least favorite chief complaint of all emergency medicine is G-tube problem. That's my one. I hate it. Freaking hate it. So trachs are a close second, because it's just not normal, right? But then, G-tube, no big deal. This goes bad, we got problems. So I get very frustrated when our respiratory therapists, who are outstanding, do stuff to trach problems without me in the room, because I've had them go bad, right? Who's had them go bad? Right? Oh, not enough of you. Good luck when it does. It will happen. So I think the biggest thing is obstructed is this just a simple mucus plug, or is there something else going on? And you have to be careful what you put in there. I think it's tempting to say, I'm gonna slide a bougie down there, and Ms. Salim said that's pretty stiff. You could cause a lot of trouble. So the first thing is one of those little suction catheters for trachs. I don't know where they are. Respiratory has them. They're somewhere in the airway box in the airway car. Get respiratory. I think I can't remember your name. I'm sorry. Jen? No, Jen. Rachel. By the end of the day, I'll get it right. Bring friends, right? This is not just you in the room by yourself. So bring friends, have extra oxygen, have your end-tidal CO2. I think that was the best thing from the article that I took away. Hey, make sure that's on. But just, can you pass the suction catheter down? If you can't, now you have an obstructed tube. So the next thing is take out the inner cannula, if there is one, right? Most of the time they have it. I forgot the first step. If there's a cap on it, take it off, right? Or speaking valve. Simple things first, right? It's not supposed to be there. And just kind of go through that algorithm. The article that Mike sent us was outstanding. We'll tweet that out later. Mike Weinstock did a great review on it on MCRIT last spring. So can you pass the suction catheter after you take off the speaking valve or the cap or whatever it is? No. Take out the inner cannula. If that doesn't work, you can't get it down. Deflate the cuff. If it's a cuffed trach, if it's a fresh trach, it probably is in the hospital. If they've been out for a while, it's either not cuffed or the cuff's down. But check that pilot balloon, right? Simple things first. That may be what the obstruction is. And even if it's not quite right, if you take the cuff down, they might be able to breathe around the trach, and that buys you time.
So, Holly, I'm interested in this thought that you have a patient that has a trach, they've had their trach for years, they haven't really had any problems with it, but all of a sudden now you have this mucus plug and a bunch of secretions. So say you get it cleared and you're feeling great about yourself, stopping high fives, etc. Do you feel that because of this extra mucus that's been produced, that there is some sort of higher risk of a lower airway infection, so maybe even some type of atypical infection, that you would then automatically admit that patient to the hospital? Or once you clear that obstruction, do you feel comfortable sending that patient home?
I have sent patients home. Generally, it's after a period of observation. Part of it depends on what was the story that they came in with. So they've got an elderly patient that they're saying was blue and almost needed CPR, and I'm more concerned about what that episode did to them, or they have exit for a while. So first and foremost, it's the story. What kind of extremis were they in before they got to me? What do they look like when they got to me? And then if I've got a story that does not sound super concerning, it's still an observation period to make sure that I've got the patient fixed. And then lastly, it's what are they going back to? Are they in a facility with good nursing care? Do I know that they're being watched and suctioned regularly? Are they going home with the parent or the spouse who I don't really think is capable of dealing with this at home?
So it sometimes seems so obvious, right? You got this obstruction, you clear it, you can send them home, or like the patient, they were blue because they forgot to turn their oxygen on, or ran out of oxygen, or their electricity went off or something. To me, it seems like sometimes that's the case. Sometimes it's a little bit more than that. So really making sure you delve into, just like you're saying, what is the story that they're telling you, and is that all that's happening? I mean, do they get obstructed all the time? Have they had associated fever? Are they tachycardic? Ultramental stats, all those potential considerations, because it could be that once you clear that trach, yeah, you're good for the next 5 minutes or, half an hour, but then you send that patient home, and it turns out that whatever is causing the underlying problem is going to cause some further difficulty with that. So Jennifer, let's move on from obstruction to trach displacement. I know you didn't know that I was going to get to you at this point, bad luck, right? So,
That's all right.
But so give me a couple tips and tricks for a displaced tube. Maybe one that isn't necessarily you can just give us some tips and tricks with that.
So anytime that I'm going ahead and replacing a trach, besides looking at, okay, are they vent dependent, was this cuffed or not, making sure I have all equipment at bedside, go ahead, test your balloon just like you do with a regular endotracheal balloon, put the obturator in, and then again, if this is a mature tract, go ahead and follow a smooth sweeping motion down in. If there's any hesitation, I still try to avoid a bougie because, like as mentioned before, it's still semi-rigid and can easily create a false tract. So if I have any issues at that point, despite putting it in and I'm not sure I'm done, I go ahead and make sure I oxygenate the patient, either mouth and nose if they don't have a laryngectomy, or I have face mask, and I just call ENT or anesthesia.
Yeah, so that's one of those things when you're replacing a trach. You can do that sort of electively, or this trach hasn't been changed in so long, it's really disgusting, I'm just going to get it changed. And they keep getting plugs or whatever it might happen to be. But if it's an emergent thing, absolutely, you need to do all those things that you talked about. And thinking about that bougie, that false tract is what we all fear, right? That's what we don't want to have. And this is, again, of course, not a laryngectomy patient, but actually a trach patient. So, Rachel, I'm guessing, in your training, changed trachs and had that type of stuff. Errors you've made, or tips and tricks, little pearls that you've sort of discovered along your training with that?
So the last one that I changed, I will admit, I did use a bougie, I'm sorry. But I don't think that caused any major trauma. The trach went in successfully, patient did fine. I will admit though that it felt like 45 minutes in between when I pulled out the old trach and put in the new one. And the patient's coughing and there's secretions everywhere, which grossed me out too. I'm with you on that. And it was just kind of like a terrifying 5 seconds actually. So I think preparation is key, making sure that you have your exchange catheter, either an airway exchange catheter like one of the Cooks or bougie or something along those lines, in case you have trouble just sliding it in. And whatever the tracheostomy size that they had, have that one in one size down. And something I learned in doing research for this was that the different brands, the size 6 is not always the same. And so what you're looking for is the outer diameter, which is different on different sizes among different brands. So it's best if you can find out the brand, is it Shiley, is it whatever, and have that exact one present. And then have your support staff, so respiratory at bedside. And I think it's prudent to have your other airway stuff available. So like if this goes super south, I would like to have my stuff for endotracheal intubation, even though they already have one, or whatever else you would need for that available. That would be everything.
So the theme that I'm getting here is mobilizing resources, making sure equipment is at the bedside, and you're not like yelling for someone to scramble to find a smaller site. Yeah, right, exactly. That's never good.
I have to go to Central Supply, which is at the other end of the hospital, under lock and key.
Right, we're all adrenaline junkies, but not this adrenaline, right? That's not the type of thing that you want to get your adrenaline up with. So we were talking about pre-shift preparation and maybe if the shift is going to be stressful and all. When you think about things that you do in the ED, things that could be potentially stressful, I mean, this is one of those things, and one of the big reasons, I mean, of course, depending where you work, is not an incredibly frequent thing in certain situations. In other places it might be more frequent, but finding the things that you're less comfortable with, and I love something that you said when you do the teaching. Now, I will say that, you've sort of outed yourself here, that you're asking them, and you have to do the opposite, so now they can do like a reverse psychology and tell you what, whatever, right, yeah. So anyways, sorry if that sort of ruined it for you for your teaching going forward. So let me actually, if I could move it to you for two things, put some like data on this, and we will put some of the references on the Twitter feed as well. A lot of this stuff, if you just go to Rebel EM, the articles, and actually pretty in-depth and very nice discussion of those, especially that Banerjee article that we talked about before, VL versus DL. All that's on the Rebel site. It's super easy to reference when you get there. But if you could just give us a little bit of info on some data with this, maybe some studies that might be relevant to this discussion, as well. Our third, so we have obstruction, we have displacement. Our third consideration, talking about adrenaline. Bleeding, yes.
So there's not a lot of robust evidence when it comes to tracheostomies. A lot of it's going to be review articles and observational type stuff. So I don't have anything robust that's going to change anything that anybody's set up here. I think having an algorithm and understanding the anatomy of what a trach is are probably the most important things, and then when it was put in, and then the reason it was put in. So a lot of times people have these things put in because they have some stenosis somewhere up higher, or they have some mass that's like eroding into things. And other times it's just because they were a long beam from the vent. And I think those are two different types of patients. I think most of us would agree with that. I think as far as evidence goes, not much. So in my head, I don't have mobilized resources. I work out in the community. I oftentimes don't even have a respiratory therapist. So I have a set kind of algorithm that I follow. And I think if you follow this algorithm, you'll pretty much be able to figure out all things, and I'll end with the bleeding at the end of that. So the first thing is that you want to use two oxygen sources. You want to oxygenate from the nose and the mouth, as well as from the tracheostomy. And that's really important because if this is obstructed or there's a false passage, you know that they're getting some sort of passive oxygenation from above. So that'll buy you some time for oxygenation. The second thing is if they have some kind of cap that's on there, you want to take that off like we talked about. I like to remove the inner cannula, and then I like to suction to make sure there's no obstruction. And then the last thing I told you have to know the anatomy of the trach is it cuffed or uncuffed? If it's cuffed, I like to put the balloon down in the first set of scenarios that we were talking about, because now you got kind of like around the trach, you can also oxygenate. With bleeding, it's going to be the exact opposite. So you actually want to hyperinflate the cuff to put pressure on whatever potentially is bleeding. The other thing that you can do is you can come down here to the sternal notch, and you can also put some direct pressure over the trachea. And then the kind of most weird complication is the tracheonominate fistula. You can actually take the trach out, put your finger into the stoma, and hold some pressure internally, like back out towards you, to kind of stop the bleeding. Other things that I've tried that there's not a lot of evidence for is nebulized tranexamic acid. This is kind of stretching a little bit, but you put a gram in 5 cc's of normal saline and you nebulize it through the trach, and that can sometimes help. I actually do that for post-tonsillectomy bleeds, and I've also done it for hemoptysis as well, with pretty good success. So don't forget about TXA. It's a cheap drug, it's not hard to use, and it's super easy. Your respiratory therapist may look at you like you're crazy, but it actually works pretty well. Did I answer all the questions that you were? Okay.
So,
Can
guys,
I-
thank you.
Can I jump in
absolutely.
quickly? Cindy made a good point about why and when you're talking about when a trach was placed, a trach that was recently placed, you're thinking fresh surgical site, so you're thinking is the bleeding coming from the trach site versus further down. So a newer trach is more likely to be post-surgical bleeding or infection. A later trach, so let's say it's been there now for 6 or 8 months, is more concerning for the innominate artery bleeding. So with a later trach, it makes me more nervous. I get ENT involved sooner. I usually always get ENT involved on a late trach bleed. With an early trach bleed, so they've just had surgery the last couple of days, you're more likely to have the bleeding right around the site. My other trick is doing some injectable epinephrine. You've got lidocaine or marcaine in the department with injectable. You can also put some packing around there, and then with the cuff tube, you can also anteriorly pull some traction so that that cuff is up against the site to provide a little bit better pressure as well.
All right, well, Michael, Holly, Jennifer, Rachel, Salim, thank you so much. We'll see you guys back in just a little bit.
All right, guys. Thank you to this. Thank you again to this incredibly informative panel. This all-star lineup. I know it says that we have a little bit of a break, but we're going to just power through rather than sort of stopping that discussion. Our next presenter is Dr. Courtney Smalley. Dr. Smalley. Yeah, come on up top. Dr. Smalley is the assistant professor for emergency medicine at Cleveland Clinic Metro Healthy in residency. She completed a fellowship in ultrasound, primary focus in emergency bedside ultrasound. She's very interested in educational practices of medical students, residents, and attendants. Doctor, thank you so much.
Thank you guys for having me. Thank you so much for inviting me. I come from the northeastern part of the state. We drove down here, myself and my colleague Dr. Custer, who will be later on this morning. And I'm here to talk to you guys about pulmonary hypertension, the crashing pulmonary hypertension patient. My hope is to give you a couple tips here. That is not my lecture. Give us 1 second. So I'm going to do a couple different things. So the thing with pulmonary hypertension is what you guys need to realize is that the physiology is a little bit different. And I work at Cleveland Clinic main campus, so what I see is a lot of these patients come through our department. We are one of the pulmonary hypertension centers. And, all right. And then we're going to go straight into how do you save these patients' lives when they come into the emergency department and they're crashing out here. So